Hey everyone, and welcome to the 48th episode of the Liam McCullum Show. All right, so this podcast is with Kendall Cotton from the Frontier Institute, and we're talking about a bunch of major healthcare reforms that the Montana legislature passed this session, including the repealing of certificate of need laws, the acceptance of direct primary care. We also get into the history of healthcare in the United States, why it's become so expensive, and why the United States does not have free market healthcare. Remember to subscribe to me on YouTube, Spotify, and Apple Podcasts. Like, share, and give me a 5-star rating. And I hope you enjoy the show. Here's Kendall. All right, Kendall, it's awesome to have you on.
Thanks for having me.
Yeah, do you want to just introduce yourself and maybe tell people what the Frontier Institute is doing?
Sure, absolutely. So I am the president and CEO of the Frontier Institute, and we founded the Frontier Institute in 2020. And we are a free market think tank based here in Helena, Montana. And we founded the Frontier Institute because we really felt like for a long time in Montana, it was a one-sided story where the only solution being told to legislators and the public to all the problems that we faced in our state was more taxes, more regulations, and more government control. And we really didn't feel like there was an alternative story being told that, maybe we should try free markets and less government, and that can be a way that we can solve our problems even better. So that's why we exist. We promote the free market solutions to the problems our state faces.
How have you guys been received? Are you guys gaining a lot of attention?
Yeah, we have. We just ended our first legislative session. Montana meets with their legislature, every other year. So we just wrapped up the legislative session, and several of our policy priorities made it through to the governor's desk and were signed. We're very happy with how things turned out, and to be quite honest, I think that states around the nation ought to be looking at Montana right now because we passed a whole slate of free market healthcare reforms with some really, really big, priorities that have been, talked about for a long time nationally, like repealing certificate of need laws, promoting direct primary care, expanding telehealth. And Montana did all those things. And, Frontier was very fortunate to be able to play a role in delivering those wins for Montana.
Yeah, and I definitely want to get into those, specifically Senate Bill 101. But before we do that, I think it would be beneficial for the listener if we got into like the history of healthcare in the United States. And then if there's any like distinct differences, particularly in healthcare in Montana, different from other states prior to this bill. But yeah, do you want to just give a quick history of what healthcare has been like in the United States?
Yeah, I mean, that's a that's a long, complicated question, sadly. But from my perspective, I think that the history of healthcare in the United States is really a story about government getting involved and really screwing it up. So in my assessment, I think really we ought to go back to the early 1900s to start. So prior to the early 1900s, healthcare in the United States was pretty much unregulated. And in fact, we had the most doctors per capita of really any other industrial country in the world. So we had kind of a robust medical system developing with lots of different schools of thought. There was competing kind of schools of thought in medicine of different ways of going about treating illnesses and things like that. And then what you saw is in 1910, the American Medical Association crafted this report and basically started lobbying state legislators and the government to say that we should only license a certain type of medicine, a certain school of medicine. And we ought to have all these, kind of strict requirements for education and qualifications to be a doctor. And, that's where you heard kind of these classic stories that you hear about, snake oil salesmen going to, these Western towns and duping people into these cure-all medicines. And for all intents and purposes, that's a fictional story that was spun up to gin up fear to pass these sorts of licensing measures. And what that did is it effectively over the next 10 years, so from 1910, the next decade, you saw literally half of the medical schools in the United States close, and you saw the number of doctors in the United States get cut in half. A lot of those doctors were minority doctors, Jewish institutions, a lot of female women doctors. that got kind of elbowed out with the new licensing regime. And from that point forward, I think you have kind of a downward spiral where you have costs going up, but you have less access because things cost more. And so people are priced out of healthcare. So you have those massive supply restrictions with those licensing requirements in the early 1900s. And then you've coupled that. So jump forward to World War II, that's when we saw the real expansion of insurance. So during World War II, there were strong wage and price controls. And it was an attempt to help the economy, deal with the war and finance the war and things like that. But employers ended up offering bigger benefit packages in the form of health insurance as a way to attract potential employees. So they actually ended up lobbying the government, and the government ended up exempting all employer-sponsored health insurance from income taxes. And so that created this massive demand. And so employers said, hey, we can escape a lot of tax burden if we just offer bigger benefit packages, more comprehensive health insurance. And so that really boosted demand, because the number of millions of more Americans were getting covered by insurance for all these different comprehensive healthcare needs. And so that really boosted demand. And so when you have a boost in demand coupled with restrictions on supply, you have a recipe for higher costs. And so, over the rest of the decade, you saw an increased, we saw Medicare and Medicaid get enacted that boosted demand even more. We saw other supply type restrictions like certificate of need laws emerge in the 1970s, which restricted supply of, medical facilities. And so that's all, kind of led to today, where we have this situation where the United States spends the most on healthcare out of anybody else in the world. And, especially here in Montana, we actually have some of the highest healthcare costs in the nation. So from my mind, it's really driven by a crisis of supply. I think that's fundamentally where it is, but it's a vicious cycle, because you have government restricts supply, but then it incentivizes and subsidizes demand. And so that's just a vicious cycle that leads to higher and higher prices. And really, there's no end in sight unless we can, develop alternative systems.
Yeah. So with certificate of need, that happens at like the county level or something like that, right? It's pretty local.
Most certificate of need laws are on a kind of a state by state level. And for those who don't know what certificate of need is, I mean, it's like something out of, communist Russia. It's in order to start a healthcare business under a certificate of need regime, you need to get permission from the government in order to start your business. And it's even worse than just getting permission. Before you can get permission, the government then surveys your would-be competitors and says, will this cut into your bottom line? Will this new business competition cut into your bottom line? And that's a really, really bad dynamic for, just market function in healthcare. So that's a really damaging law. Thankfully, Montana passed a bill to repeal almost all of our certificate of need laws this year.
Yeah, so where in Montana, where did that happen? Was there a board that determined whether or not there was need in Montana then?
Yeah, so there's a state level kind of commission set up that created basically an assessment of need each year, kind of estimating, how much home health services are needed, how much, nursing homes are needed, and all that sort of stuff. And the calculations, when they got new applications in the door for new home health providers or whatever, they referred to that assessment of need to determine whether they should approve those applications.
And I'm sure there's a revolving door there with like in and out of these big hospitals and that board then.
Maybe that's not something I'm aware of, but I think that that's the concern when you have these sorts of programs. I think another example of kind of what you're talking about is the way that, Medicare and Medicaid set their prices. It's not based on willing buyers and sellers. It's a prospective payment system based upon, kind of this Marxist sentiment of, labor has value. And so it's this idea of we're just going to compensate you for what it costs in terms of your time to deliver a service. And it's not based upon market interactions. So it's like price fixing, and it's really, really damaging.
Yeah. So with this Senate Bill 101, then what does it do? It's the I think it redefines the definition of direct primary care.
Yeah, so Senate Bill 101 was a really interesting proposal because a lot of different states around the nation have already kind of gone down this road, and they've allowed direct primary care, which is basically like a monthly membership for primary care services. Doctors and kind of independent practitioners, they offer primary care services, and they post all the services that they offer up front on their website. And it's a lot like a Netflix subscription. So you pay $70 a month on average for unlimited access to these services. And in a lot of ways, it leads to a much higher quality of care and provider interactions. A lot of these doctors kind of pride themselves in being able to, respond to texts on the weekends and, show up at your door, do a house call like the old fashioned doctors used to do. And so it's a really a new paradigm in healthcare. And what Montana did is something that's really important, because what's prevented this model from really expanding across the United States is overzealous regulators, particularly insurance regulators, who want to consider these memberships that don't have any sort of relation to insurance in terms of risk bearing or anything like that. The regulators see these DPC memberships as insurance. And so that would require them to go through all the hoops and regulations and red tape that insurance companies need to do, even though they aren't that. So that's been prohibitive in a lot of other states. And so what this law did is it said that direct arrangements and direct primary care is not insurance, shouldn't be regulated like insurance. It's a completely separate thing, and it's sanctioned under the law. So we created what's called a safe harbor. Basically the government saying that it's okay for these arrangements to exist, and they shouldn't be regulated like insurance just for existing. But the unique thing about Montana is that, with this bill, we're kind of thinking bigger beyond primary care. And we're the first state in the nation now to allow direct patient care agreements for all types of medical providers, primary care, but also mental health providers, dentists, chiropractors, even some specialists. So we're allowing kind of maximum freedom for doctors to really, medical entrepreneurs to really just implement this model and develop new ways of caring for people. And the cool thing about the model is that it bypasses a lot of that broken system that I was just talking about, the history of healthcare, because a lot of the features of that broken system is bureaucracy and all the insurance middlemen involved in order to deal with these really high costs. And with DPC, direct primary care and direct patient care, we're getting back to this free market idea of medicine, where it's willing buyers and sellers, and it's people offering a product for a specific price point.
Yeah. So what were the objections to this bill originally? Because I know Bullock vetoed a bill similar to this.
Yeah, the objections that Bullock kind of outlined in his veto letter, and I think he's actually vetoed it a couple times in a couple different sessions. The objections that he outlined were really rooted in, kind of this urge to protect the ACA and Obamacare as a kind of a reform to the American healthcare system. And the idea was, these direct patient care agreements, are not like comprehensive insurance plans. And so they're not offering a full suite of services like the ACA mandated insurance to cover. And so, the Bullock administration characterized these plans as like, junk insurance. And these are just, kind of useless plans that are redirecting consumer dollars and healthy people away from the ACA marketplace. And, fundamentally, that's not true. I mean, in fact, I know a lot of folks who are uninsured, underinsured with, catastrophic healthcare plans and really high deductibles, and even some Medicare and Medicaid patients who utilize the direct primary care doctors here in our state because they really feel that it's a better value for their dollar. So they're willing, if they have a high deductible plan, they're willing to pay, $70 a month to then get really, truly unlimited access to a doctor.
Yeah. And then I know another objection was that DPC can't handle emergencies, but I'm not sure that's like an argument against it, like to regulate it to the ground.
Yeah, that's just kind of misunderstanding the concept, I think. And I think it's really rooted in this idea that I think a lot of folks on the left have had for the last couple of decades, that insurance coverage or Medicaid coverage or Medicare coverage equals health care. And that's just not true for a lot of Americans these days. When your deductible is $5,000 and most Americans don't even have $1,000 in their savings account, you don't have access to healthcare.
Yeah. Whereas, I mean, I know I could afford a subscription service, especially because, like, if I walk into a healthcare facility now, like, I could walk away just a checkup, $200 maybe. They won't tell me. They won't tell me up front what it's going to be, and it could be $200 to $300 based on what they do. With
Yeah.
this, I know, well, I'm paying this much this month.
Yeah, that's one of the big challenges with the current system is, that price transparency, because that's something you don't see in any other market, is these opaque prices and this secret pricing where you get a bill after getting your service and you have no clue what it might cost. And it varies widely too, between hospitals, between providers, or even where you go in the hospital. Your bill could be different for the same service. But one of the cool things is, I'll give a really good example. So my hospital, local hospital here in Helena, charges, it's around $100 for like a standard lipid panel blood test. Blue Cross is a really popular insurance plan in Montana. They reimburse the hospital for that lipid panel around, I think it was around $20. See, I'll check my math here. Yeah, around $20. If you have a different insurance plan like Pacific Source, which is another common insurer, they reimburse around $98. So that's still pretty high. But the direct primary care clinic down the road offers those blood tests as well. And they can say up front on their website that they can do a lipid panel for $7.50, no more, no less. So that's some pretty incredible cost savings. And it's all transparent and upfront, so you know what you're getting right when you walk in the door.
Yeah. So something that I've been confused about insurance companies and the way that prices are determined is, like, I guess I just don't know why it would be more expensive. Is it just because there's a third party involved? Because I think that a lot of people in America, they think that these insurance companies are lifting the price off their shoulders. So when you tell them, well, you don't need insurance, you can just have an agreement with your doctor, they're like, well, but who's going to cover the cost?
Well, I mean, we should remember too, it's not totally the insurance company's fault. I mean, they're trying to reduce costs. They have an incentive to do that, so they can make a profit, and they are dealing with a lot of regulation. So there's a lot of, we talked about the ACA. There's a lot of mandates on insurance companies that says that they have to offer coverage for particular things, even if the people they're covering don't want those things or don't need those things. So that drives up the cost. In addition to that, I mean, there's this thing called network adequacy. So that's where I learned about in the insurance commissioner's office in my past job. And it's this idea that, so say you were trying to start a burger joint, a new burger joint, you're going to offer sandwiches to folks, and you apply to the regulator of burger joints. And in order to be licensed, you have to buy land and put a facility on every street corner that McDonald's also has a burger joint in order to get licensed and qualify as a legitimate burger joint. That's what network adequacy is for insurance companies. So it really limits, kind of newcomers from coming into the marketplace and saying, well, we're just going to cover a small area of the state. We're not going to go to the whole state. There's laws that say that insurance companies have to offer coverage to 85% of the state. So that's a big barrier too. That increases costs. But beyond regulations, it really gets back to who pays. So it's, I think, the classic example that Milton Friedman gave about the economization of value. So it's, if someone else is spending someone else's money, there's not a lot of incentive to spend it wisely. But if I'm spending my own money for myself, I have a very high incentive to spend it very wisely and seek the highest value. And with insurance companies and different middlemen involved with your healthcare dollar, there's a lot of ways that they aren't seeking the highest value, and they're really just looking to maximize their profits. So there is a lot of kind of that predatory behavior in this middleman system. And the other thing we deal with too is, especially in a state like Montana, is really, truly regional monopolies. You have these hospitals that control, large swaths of the state and different healthcare populations, and insurance companies, their hands are really tied when they go in and they need to cover that portion of the state under the regulations that we just talked about, but they really just have to kind of take whatever price that hospital wants to charge. And they can negotiate as much as they can, but at the end of the day, it's kind of in the hospital's purview to charge whatever they want. So that creates a recipe for really high costs. And so from my perspective, really the real answer here is reducing restrictions on supply. So we need to boost more competition and choice in the marketplace, reduce regulations on building new hospitals and new healthcare facilities, reduce restrictions on new medical providers getting licensed, and then also stop these subsidy programs that give unfair subsidies for these monopolistic actors and these big hospitals and things like that. I think that would go a long way to getting us back to a market-oriented system.
Yeah, because I've heard it explained that like the healthcare facilities will look at your insurance plan and then determine what they can charge you based off of that plan. So, I mean, is that an accurate portrayal of how it happens?
Yeah, and in fact, they're contractually bound to do that. So I mean, they enter into network agreements with insurance companies. So if I'm a hospital, I enter into a network agreement, and what that means is that all of the insurance company's members can go to my hospital and get an in-network rate. And so that's a rate that I've negotiated between my company, the hospital, and the insurance company. But really, what those rates end up being is a percent of discount off of the hospital's charges. But remember, what are the hospital's charges? It's whatever they want it to be. And when you have the hands tied of insurance companies, it really it limits their ability to negotiate that down farther. In addition to that, we talked about the prospective payment system of these government programs, which that's not based in negotiation at all. It's basically this commission or panel that sets prices based upon how much resources they think goes into delivering that service and how much those might cost. So it's a truly messed up system.
How fast do you expect the market in Montana to move? Like, I told my friends about this bill, and they're like, okay, well, where do I go next? Is there a direct primary care facility here? Is there a way to find people?
Yeah, there's a lot of resources to go and find different healthcare providers. You can go, I believe the DPC Frontier, it's called, has kind of a map that you can look at of all the different DPC clinics across the nation, but also in Montana. A lot of the ones in Montana are listed there. Right now, Montana has 8 different DPC clinics in most of our major cities. So the most recent one just popped up here in Helena, and it's a young guy who just graduated medical school, and he's very excited about getting involved with the community. It sounds like a great service he's providing. But with this new bill, now we've opened the door for not just these primary care clinics, but for specialists and people of all sorts to start experimenting with this. So I've actually gotten a call from a specialist who moved here. They want to retire, but they don't want to fully retire. They want to continue practicing medicine. And so they're setting up a kind of a mobile specialty clinic to go service rural, kind of underserved areas and offer dermatology and other specialty services like that to those areas that might not, have access to those kind of services. So I think that a lot of innovation is going to pick up here, especially with this regulatory certainty. That's been a really big, thing that's prohibited development of these clinics in the past.
Yeah, it's really awesome to hear. Are there any more healthcare bills in Montana that you want to talk about, or any other bills that you guys supported?
Yeah, so a really interesting one that ties into SB 101 was SB 374, and that bill allowed doctors to dispense the medicine that they prescribe. So Montana, up until now, has been one of the only 5 states that doesn't allow doctors to do that. And it goes far back. I mean, this has been something that has been debated over in Montana since the 30s. But it's really been the result of a turf war between pharmacists and doctors. And so they've lobbied the government to exclude and elbow out their competitors. And what that's led to in Montana is, doctors being unable to, dispense different drugs to their patients after they prescribe it to them, save them from having to go and make another trip to the pharmacy. And they weren't able to do that unless they were outside of 10 miles around a community pharmacy. The problem is there's almost no doctors in Montana that will qualify for that under that arrangement. So it was really this protectionist law. And the way that it ties into DPC is with direct primary care, I talked about their ability to offer really, really cheap lab pricing because they're able to cut out all the middlemen and just offer it at cost. They can do the same thing with prescription drugs. So they can buy drugs at wholesale prices, and you get to skip the the insurance company and the PBM, whatever kind of markup or rebates they've got involved there, and then the markup at the pharmacy. So you remove all these different middlemen from the supply chain, and what you find is that you can get prescription drugs a lot of times cheaper and for pennies on the dollar. Sometimes it's not cheaper. Sometimes if you have insurance coverage, it still makes more sense to go to the pharmacy because they've negotiated better rates or whatever. But this law that Montana passed allows patients to have that option. And it's especially useful for direct primary care practices because they're not looking to, make a profit off of this. They just offer this as an additional service included in their fee. And they will, just offer drugs to their patients at the cost that it, costs them to get it.
Yeah, that's really awesome to hear. Well, if there's anything else that you want to talk about, any other bills you want to bring up, please do. And then we can let you go.
Sure, absolutely. I mentioned a couple other bills. We talked about certificate of need. We talked about direct primary care. We talked about this physician dispensing medicine. We also expanded telehealth this year, which is a big deal. During the pandemic, there were a lot of emergency actions, and some of those emergency actions were mandates and things like requiring masks. But some of the emergency actions were very positive, and they were reducing some of the red tape and regulations that were restricting providers from offering things like telemedicine. And one of the things about Montana's laws is that we prohibited audio only, just regular telephone telemedicine. So mental health providers couldn't just call up somebody and who was in a crisis and talk them down. And so that was really a restriction on scope of delivery, and it really didn't make a lot of sense. And so that law was waived during the crisis over the last year. And so lawmakers in Montana unanimously got together and said, hey, if these laws had been waived during the pandemic, if we had to waive them to boost access to healthcare, why did we need these in the first place? And they unanimously, repealed that law permanently and a couple other different restrictions on telehealth. So that was really, really good to see. And my hope is that we can kind of continue that momentum. I think lawmakers are kind of understanding that we can boost access to healthcare by repealing some of this unnecessary red tape and regulations that, just artificially restrict the access and choices that people have.
Yeah. So I guess my last question then would be, where do you want to go in the future? What's your next goal?
Yeah. Well, I think that we got to do a lot to, promote these free market alternatives to this, the current system we have. I know there's a lot of folks on the left who say that, single payer is the way to go. But from my assessment, that's just more of this really broken system that we have, and it's going to end badly. It's going to be very costly. So I think the more of our efforts that are spent promoting these kind of really free market alternatives like direct primary care and direct patient care, and these really transparent cash-based alternatives, those will be efforts well spent. But I also think that, based upon, I think the history of medicine in the United States, it's fundamentally a supply issue. And so some efforts need to be spent on reducing the licensing restrictions for people to get licensed to be a medical provider, loosening up the scope of practice. So an example would be allowing doctors to dispense medicine. In a lot of ways, we can allow providers to do more with their qualifications. And laws, in a lot of ways, stand in the way of that. So I think that that's where our efforts are best spent right now. And that's kind of what Frontier is looking at.
Cool. Well, Kendall, if you want to tell people where they can find you at the Frontier Institute, please do, and then we'll let you go.
Awesome. So yes, please go to our website, frontierinstitute.org. We post a lot of content on the website. We also have a weekly newsletter that you can sign up for there. We provide updates on policy, current events, and kind of legislative focus happenings in Montana weekly. So please sign up for that, and please reach out to us if you are interested in any of the ideas that we talked about here. I know healthcare is a really complicated subject, and in my opinion, I don't think the free market side of things has really had a cohesive policy platform to run on here. And that's kind of what our role is. We're trying to put together solid solutions that folks can get behind that are an alternative to just using government to fix all of our problems.
Great. Well, thank you so much, Kendall.
All right. Thank you, Liam.
It's the weekend, we can let go. It's the full send, it's the get-go.